Can I see here how many people joined us? Not yet. The presentation is on.
I'll just give it another few seconds.
Yeah.
Yeah, many people register.
We had around 5-6 people registered, then loads of them wanted to join online. Let's see.
We had a few messages last minute this afternoon asking for the link.
Oh, okay, that's good. This is the first time we're doing both, and this is ever so new for us. We were testing out the camera height and everything because we want to record and use it again later stages. That's okay. Yeah. Shall we start? So, thank you for coming. Let me talk to the camera as well. Yeah. Otherwise, I get the grip. So, how many of you think cortisone injection is bad for the health or bad for the body? Anyone who's on live, you could speak to us. Maxine is online. And you think it's bad?
Possibly.
Okay.
Hopefully
Too
reduces
many
pain.
injections.
Yeah.
Too many injections.
Too many injections. You're absolutely right. You know, in UK itself, we are a small island. We get around 500 cortisone injections in a year within this country. When you compare the size of the population and the percentage of people go for the steroid injection, is quite a high number. And it's so high or too high in Scotland, because Scotland is being a colder nation and loads of people get rheumatism, rheumatoid arthritis, inflammatory arthritis. So they get loads of steroid injection. It works really, really well for those kind of conditions. Even though this steroid injection effectively reduces the inflammation significantly, we always give a bad press to the steroid. There is various reasons why it's getting the bad names out on the press, but at the same time, it's worthwhile exploring how good it is. Is it right for you? Or can I have it? If I'm going to have it, what are the problems I'm going to face in the future? This is all I want to talk to you about. On top of it, if you think steroid is not the right one for me, is there anything else, alternative therapy, can I consider? So, next one. So, what is cortisol? It's a normal drug or a chemical, or you could call it as a hormone, which is produced within our own body. It's mother of all the anti-inflammatory drugs available. And if you remember the glands, pituitary, cortex, which is adrenaline cortex, which is right above the 2 kidneys, that is where it gets produced. And then it gets within the body and goes all over. This is what helps people to grow, the children to grow, and the body to regularly metabolize the drugs so that the body keeps the inflammation at bay. Otherwise, your body is constantly fighting the inflammation. If the immunity is low, the inflammation wins the game. If it's the other way around, then you get an autoimmune disorder. So it's a constant battle between the body inflammation and its own healing mechanism. And the steroid is the one, or corticosteroid, which is produced in our body, is the winning card holder. Without this steroid, the body cannot function. If it goes up, it's a problem. Goes low, it's a problem. But as we get older, the body produces less amount of steroid within the body, and hence humans have produced synthetic drugs to help the problems. So it's a chemical man-made product, which substitute the actual substance produced within the body. So in one sense, it is same, very, very good normal chemical, nothing wrong with it. We couldn't produce enough, so we are putting it through either drugs, tablet form, or injection form. Okay? But you don't want to confuse this with anabolic steroid. Anabolic steroid, this is where people use to build the muscle building, gym going people, they regularly inject the shots in their bum. That is completely different. That's anabolic steroid, completely different from what we use it here. Okay? So, is there any good by using this cortisone quite regularly? So yes, it has got loads of good effects in the body. It creates a window of opportunity to manage the symptoms where you can help your body to get better, i.e. you got a painful joint and you get the injection, so it helps you to do the exercises so that you strengthen the muscles around the joint and put enough or reduce the amount of weight bearing goes through it. For example, you got an inflammation very local to one particular part of the body. Why do we want to put this mother of all the drugs in the body, which goes around all over the body, then becomes a drop in the ocean? You get very little to the localized area. For an example, patients with the thumb arthritis, the problem is right at the base of the thumb, very small area, very localized. If the doctor puts you on 80 milligram of steroid as a oral tablet, which goes all over the body, gets through the bloodstream, then comes to the kidneys, goes to the liver, gets synthesized, comes back to the kidneys, and then flushed out. But if I could do 1/4 of the dose, 10 milligram of steroid, right into that area, which will stay here for at least 2 to 6 weeks, produce amazing effects, none of our body will get exposed to the powerful drugs. That is the beauty of it. You could put it in a very localized spot and reduce the inflammation very effectively. There are some other tendons which are highly inflamed. For example, decruent tenosynovitis, which is one of the very painful condition. You know, people who use the mobile phone often get a repetitive strain injury right over there. That's called decruent tenosynovitis. If you get it, it's quite painful. You could try anything. I said take painkillers, put the rubs on it. You could try anything, but steroid, one shot of it works amazingly well. But you need to put at least 6 to 8 times of the drug what we put in that area through the body to get at least 10% of the effect what we get from one shot in that area. So, but at the same time, if you got a arthritic knee joint, there is nothing much out there helpful, but this drug takes away the inflammation, gives you good night's sleep, and it can be pain-free, keep you pain-free for at least 6 to 12 months. It gets you walking, and it keeps your body healthy, and it get on with your quality of life. So it is very effective in quite a good areas. But at the same time, it is bad if we repeatedly do it. That's what you clearly mentioned. What happens if I'm going to do it often? So this is what everybody asks me this question. How many can I have it in a year? I hear that only 3 I could have. Is that only 3 in my lifetime? There's no limit. It's only the clinician, people like me or your doctor will decide how many you could have. But the best practice is you don't invade the joint unnecessarily if the problem isn't that bad enough. For example, you got a knee joint arthritis, you got a knee joint pain, but you got a holiday coming up. You know, you are looking forward to spend some time with the family and the wife. You could have a lot of lovely walking. Why do we ruin it? Get the injection. We know it's going to last only for another 6 months. But that 6 months worth the time, so you get a good quality of life with the family, make lots of memories, is worth the shot you take. But again, you don't need to have it for another 6 months, 12 months, 18 months if you can keep away from it. Some people come back to me saying, you know, I had a lovely holiday. Now It's affecting my quality of life. I can't sleep. It's throbbing every single night. I can't have a surgery. I can't put on any medications because I'm already on loads of medication or I'm not allowed to take this kind of medication. They have nowhere to turn. This is one of the treatment options. But again, how many we inject, it's very carefully calculated. I don't mind doing a bit more in the knee joint, hip joint, shoulder joint, ankle joints. Shoulder joint, if you've got a frozen shoulder, and if it's a very stubborn old frozen shoulder, you can have up to 5. 5 within, say, 3 weeks interval. So, it's a careful calculation how many you could have, it depending upon your body weight, depending upon your kidney function, depending upon your heart conditions, all those information we will be checking before we do it. Tendons. What are the tendons we regularly inject? Is the shoulder, what we call it as a rotator cuff tendon, then tennis elbow, golfer's elbow, De Quervain's, these Achilles tendon, hamstring tendons. These are the patellar tendon. The whole thigh muscle goes and attached to your knee joint. These are the tendons you don't want to repeat often. Some of these tendon, I don't want to touch it at all, but some of them I would inject at least once, then I'll say no. Whatever the situation is, I don't want to touch it. Achilles is same. I would do only one. So I'll tell them, don't waste the drug. Look after the joint after the injection, the tendons. Come back to me maybe after a year. In between, whatever happens, I don't want to hear about it because we will damage the tendon. Once the damage is done, then the tendon will rupture. Nothing can be done. And there are other little problems like skin thinning, fat atrophy around that area, discoloration, and all those things can happen. That means, if I inject somebody here, I would tell them you will have a white patch for at least 18 months. If I inject there, I'll tell them you'll have a dip. So you need to be aware of this. And if anybody had an injection here, you will clearly see a dip. This fat has been slowly washed away by the drugs. So powerful, they absorb the fat. And if people understand these are the possible side effects, they accept it. If not, people will get upset about it. Last one, it increases the blood sugar level. And we underestimated, medical community have underestimated how badly that alters the blood sugar in the body. Another one, peripheral neuropathy. I've injected 2 of patients in the hip joint. They developed constant pins and needles, tingling in their feet. Been to the hospital, had an MRI scan, everybody thought the pain is coming from the sciatic nerve. And been to the hospital, then they checked everything, what are things he had. It was the steroid, which increased everything up. That is diabetic sensitivity to the peripheral nerve. So he had diabetic neuropathy. It took 4 weeks for him to settle down. He had no pain after the injection in the hip, no pain at all. He was ever so happy. But he said, Xavier, he introduced me all this diabetic neuropathy. But a good point was, he was tested for diabetes after that. He was borderline diabetic. They put him on the drugs, everything sorted. So these are the things, bad things we underestimate out of the drugs. Next. Is there alternative medicine or substance available to the steroid? Or do I need to just take the steroid all the time? There are loads of people, if you imagine in my practice here, out of 10 patients, I could inject only 6 of them. So out of 1 million people in Sittingbourne and Sheppey, only 10 people come to me for an injection. Out of that, I could do 6 to 8. Why? Because they will have complicated medical history. They are already on too much of drugs. I think their heart may not cope up with the demand these drugs will put on their body. And their kidneys are not coping well already. If a patient has a chronic kidney disease, I wouldn't inject it again and again because the kidney cannot synthesize the synthetic nature of the drugs. It will slow down the function of the kidney. It'll be too painful. So in the effect of not giving too much trouble or a burden to the kidney, we use another product, something like this. So we use two of the products if you guys want to just check it out. This is very, very interesting, good one. This is what, you may hear people talk about gel injections. This is the gel injection many people talk about. It's absolutely effective for weight-bearing joints. For example, hip joint, knee joints, all those things. So it's quite thick in the nature inside, very, very thick. It's like a toothpaste. I was worried whether this toothpaste will go through the needle into the joint. Actually, it does. And so this effectively lays a coat over your cartilage and creates a suspension effect to the joint and keeps the pressure off of the cartilage or worn out part of the cartilage for longer. This one, Max, the next one, please. So out of these two products, this one lasts very long time. For example, it lasts around 18 months to 2 years, depending upon the body size and the nature of the problem. This one, much thinner version of the same substance, very, very light. I can put it in any joint, and that can last anywhere around 18 months max. And again, people who cannot have the steroid injection, people have worn out joints, these two can be of a good solution. Personal experience says, my mother-in-law, who has completely no cartilage in the knee joint, she lives in India. She comes here once in 2 years, 3 years. So she comes for 3 months holiday. So she gets one gel the day she comes in. She'll have the second dose before she goes out. She wouldn't have any problem for another 2 years. So doctors told her you need a knee replacement by around 10 years ago. Ever since her daughter married to me, she has no problem. It's quite good way, She doesn't want to take any medication. She's not on any medication. That helps. This is my favorite out of those two, because if you see the molecular texture of it, that molecules are kind of interlinked in every front, creates a very stronger bond. That molecular bonding is the main reason for the drugs or the supplements to stay in the body for longer. They are not a medicine. They are not a chemical. They are plant-based stuff. So they are very, very, eco-wise, and it's a body doesn't reject it. Because of the thickness of it and the volume is 6 milliliters we put in, you might feel a bit stiffer within the joints. For example, if we do it in the knee joint, people will feel a bit tight and stiff for a couple of days. And at least I would say to them, I'll tell them, for a week, you'll have a stiff joint. All I would tell them, just go for a nice walk and move it around. Do not embark on a long journey, blue water shopping or walking the dog for a week. Do not anticipate those things. And they can go to the normal shopping locally, walk the grandchildren to the school and back. All those things they can do. They can go for a 9-hole golf, but not the 18 holes. This is all the limitation to get the better out of the supplements first. Then they can do everything very, very normal. Sometimes people come back to and say that, I don't think this stuff worked on me. Because this is not a pain relieving stuff. It's not as good as the steroids. Steroid just takes away the pain just like that. This doesn't take away your pain. But it keeps the joint as good as, than before. So people tell me, I had the injection, but it didn't work. I still have the pain. Then I tell them, I explain them even before we put it in. It's not a pain relieving stuff. This is purely a supplement just to hold the joint wider apart, creates a little bit of lubrication so that the mechanical pressure is lost. That is all it is. You may have a little bit of discomfort for long run, but people feel quite independent after this injection and the pain level will go down. Occasional night pains might happen. Okay, so these are the very important two different stuff what we use apart from steroid. There's another one product available, PRP. Next one, Max. So PRP, this is what you must have heard. We pull the blood out of your body, then put it in a centrifugal machine, spin it around, take the plasma out of it. Have you heard of this? So this is called a platelet-rich protein plasma injection. It's one of the proteins we put it in the body. There is no rejection, there is no side effects, no complication, no nonsense, because the product comes out of your own body, so the body takes it back very happily. But we are putting just the plasma, which is full of platelets. Saying all this, scientifically, it looks really, really great. When I heard about it, wow, platelet is the important ingredient for the healing. It should just heal up. Everything shouldn't have any problem at all. But in reality, the effect is, I would say, 60-40. So loads of research went into the technique, and it cost around £1,200 to get it done locally in the hospital. Kim's, they do it for £1,700 or £1,200, something like that. A couple of my colleagues used to do it for £1,200, but the effect is not as much as what we expected. But again, no side effects, beautiful method. But somehow our body won't heal it as good as the other stuff does. So next one is the stem cell therapy. Again, stem cell, we have heard a lot about it. There are loads of research went into it. They're all artificial, stuff where we can draw your own body stem cells, then send it out to a lab, culture it, and bring it back and inject it into the painful area. The results are very mixed. That's the reason in my rating, this goes as a last option of treatment. Very invasive procedure. And again, we cannot predict the outcome. We cannot predict the outcome. How much ever you try, even though it's the stuff comes out of the body, the matrix of the stem cells are same as our body cells. There's nothing to reject. Why it doesn't work? Then later on, over the years of experience, I've realized our body is the one which is causing the pain. We are taking our stuff out, putting back in and aiming them to heal properly, may not work. So it needs a little bit of kickstart at times. That is where the chemicals and other supplements comes in and helps it. Okay? So this is another alternative options of treatment. But in this practice, you need to be qualified to a certain level with extra degrees and licensing to do any of these injections. I think in whole, if you think about Kent and Medway Towns and Swale area, probably 2 or 3 people who are qualified like me who does this kind of injection. Hanbay, we have another clinic, one of my colleagues, he does it. And I don't think Maidstone we have anybody. Otherwise, you need to go to Greenwich area. So you need to have the extra degree. It's called independent non-medical prescribing. Then we need to apply for a license to handle the drugs. Then we should have a extra training to inject in any specific joints. And we need to go through our competencies. Then only we are allowed to inject. So lots of work goes in. And the professional liability insurance itself, quite a heavy one. And we need to prove loads of stuff to get the licensing and the insurance to back us. So quite a lot of work. Then, over the years of my experience in doing all these injections, many physios who see me doing it, they all think it's easy technique. You just move the kneecap, put it in the knee joint. You find the pain spot and just put the needle in. The techniques are far easier, but when not to inject is the skill. So deciding, that's the joint I'm not going to inject. That is the skill. That is where the experience and the knowledge and everything comes in. I've been injecting for 14 years. And when I was young into this injection therapy, I would have injected 9 out of 10 patients. Now I do only 6 or 7 because I consider all the other side effects possible. If you go here, I'll be checking people's drug history. How is their kidney functioning? How is your liver functioning? How much do you pee every single day? What's your diet pattern looks like? I'll be checking their legs. Is there any congestive cardiac failure happening? That means their legs are swollen up. What's your diabetic level? And any previous procedures, surgeries, injections. All those things we need to consider. Then if some of the people are on weird and wonderful medications, I need to then check on another formulary whether the drugs I'm going to use is going to interact with the drugs what they are on. You won't believe it. Last week I saw the gentleman. He came from Spain. He came to visit his brother here. He said, let me take you to Xavier, let him inject your hip joint and everything. He came along. All the drugs are in Spanish language. I couldn't figure it out. How am I going to check with the English formulary whether this drug is fighting this or not? Then I have to Google every drugs and figure out, okay, that is your cholesterol drug, that wouldn't affect. That's for your kidneys. Then I have to ask his kidney. He says, yeah, everything is fine, no problem, no problem. It took around 1 hour for me to figure out whether to inject or not. And any investigations? Have they had X-rays, MRI scans? All these things I need to check. Yesterday there was a lady here. They came from Hanbei to get the injection done. They were so anxious. I'm in pain. I've been to many people. Nobody wanted to help me. This is the one place will help me. And they were so heavy in demanding, I need the jab now. You need to go for the extra shot. I need to have extra shot. I have to tell them I'm going to disappoint you because the shoulder looks pretty bad. I have to send them for X-ray. Without the X-ray, then I'm putting the needle into the wrong. There is already something brewing in there. You don't want to put the steroid. That's going to keep the fire 10 times higher. So I have to send them away. So I need to manage people's expectation, counsel them. If they feel disappointed, I have to tell them why I'm disappointing them. All those information goes through. So it's not just a job where you get people in, just inject them and send them away, then they live happy ever after. That magic never happens that easily. So much more you need to consider. When I'm speaking to a patient, my brain will be ticking. Yes, that box ticks. There's tick, 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 tick. No, that is not ticking. We question quite a lot about it. So much algorithm goes in my head before I say yes to this injection. Touch wood, I've been injecting 14 years. Nobody had side effects such as anaphylaxis, infection into the joint, and losing a joint. These are the 3 worst situations that anybody could have. Yes, the injection doesn't work. Yes, it can happen around 20 to 30% of the injections I do. I'll be open to people saying that, not all my injection will work for you. 20 to 30% of the injections may not work for you. But I don't want to give them infection into the joint. That ruins their life, ruins the joint. Anaphylaxis, life-threatening. Touch wood, nobody had it, even though I'm injecting 14 years. So in one sense, I'm quite conservative in thinking. I won't give it to everybody. Some people say, I'm paying you, get it done. It doesn't work like that. Loads of careful consideration. And again, saying loads of pros and cons of these procedures, still, patient will ask me, is this right for me in your professional opinion? That's where I have to say, yes, it'll work for you, but there is 90% chances it'll work of 80% of its desired effect. So for example, Gary, if you think, if I'm injecting your shoulder, there's a possibility that injection can take away 100% of your pain. I would predict, okay, 80% of the pain go away in 80 out of 100 patients I inject. So that's where the probability comes in. But there are few conditions in the body, I would blindly say yes, 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 yes to. Frozen shoulder, oh my God. Why the doctors always send the people with the steroid, the paracetamol, ibuprofen, rub and everything. People cannot sleep, they come with the baggy eyes. 1 shot. Very good. Decroins, 1 shot. Perfect. Thumb injections, 1. Perfect. Knee joint, I would vary. If it's an early knee arthritis, I would say 90% chances. You had the knee joint arthritis, you had an x-ray, the bone was pretty much bone on bone. I would say around 50-50 chances the steroid will work. These Durolane and the other materials will work another 50-50. So the probability changes depending upon the chronicity of the problem and what other comorbidities do you have. But if it's chosen well, it could be amazing treatment. And this is where the conversation you'll have with me, if you come and see me here, or if you see some of my colleagues in the NHS, all we need to balance it out. Is this right for you? Nobody want to take a risk. And in all fairness, the steroid works very, very well for many of the joints because it's mother of all the drugs. Because it's mother of all the drugs. There is no other better invention of the humans except that steroids, which is produced within our own body. If you're pregnant, you'll have a highest production of the steroid within our body. If you're running away from a dog or snake or something, that produced heavily within our body. But we can't live our life in that status all the time. But we could have it artificially, does the same job. But if anything too much, it can be too much of a problem. Okay, so that's pretty much it. Hope you have had loads of information. I'll put in a leaflet inside, which has got a load more information I've wrote about quite a long time. Loads of questions people will have. The biggest question people have, am I a right person to have it? Will it work for me? What can I do? What cannot I do after the injection? So anyone, if you have any questions, please ask us. If you're on live, please talk to Maxine and we'll get your questions answered.
I have one question, Xavier. I'm just going to show it on the screen. And you can see that. My mum-in-law has severe waist pain and unable to stand for long. She's diabetic. What will you recommend?
Okay. How old is the mother-in-law? Is it Emmanuel or somebody who's asking?
Mm-hmm.
Yes, Emmanuel, how old is your mother-in-law? So this is a very good question, actually. A mother-in-law having a waist pain. So he may be considering the waist pain can be the groin pain, or it could be the pain which comes from here. If 69, and I think by name she may be African woman. So this is where you need to be extremely careful about the heritage of the people. So African population will have increased lower back lordosis. That means their spine will be tilting too much backward, and there is a high possibility one of their spine would have slipped forward. That can give a continuous waist pain the minute they start standing. If they're going to sit down in a comfortable chair, dining chair or a sofa, they'll have no pain at all. The minute they start standing and walking, they'll have the problem. These are the people. Emmanuel, just check with your mother-in-law how far she can walk. If she can go for, say around sitting on High Street and she can come back to the car without sitting down, that means it's nothing from the lower back. But half the way through the High Street walk, if she feels quite a lot of pain, she can't stand and walk further, and she sits in a chair and bends over for another 10 minutes, that means the pain is coming from the lower back, not from the groin or the hip joint. Again, his question is waist pain. So if a person cannot cross their legs like this, cannot cut their toenails, cannot put their socks on, then 90% of the chances it's coming from the hip joint. I would inject them. So this is the way I usually differentiate. Do you have a tingling pins and needles in your legs? No, that means lower back gone, sciatic pain gone. Can you walk around the Tesco's? Tesco is the biggest supermarket over here. in Sheppey or in Gillingham. And they say, fine, I could do my shopping, come home, come to the car. Some people say that I need to lean on to the trolley, that's okay. But if they can manage that walk, that may not be from the lower back, then it could be the groin. Then I'll check them. Can you cut your toenails? Can you put your pants on without any problem? Can you sit with your leg crossed like this? Then if they can't, then it's a hip joint problem. The interesting conversation I have with people think the hip joint is situated here, right? Many people say, no, my hip joint is here. My hip joint is here. Actually, a hip joint is right into the groin here. There are two ways I can inject it. The best and easiest way to inject is into the groin. There is no blood vessel going anywhere. All I need to do, find that short groin area, just put the needle in, I'm right into the hip joint. Works amazingly well. Otherwise, I go from the side and I go right into the top of the bone and go into the joint. Slightly tricky to get to, but it works equally well. But this is the best route. Any other questions?
No, just Xavier's going to book an appointment for you for his mother-in-law.
All right, okay. Do you have any questions, sir?
No, it's all good.
So you will see loads of these clients in your practice. People cannot walk for long distances. Arthritic pain. And I always check on three things. Quality of life. I cannot bear the pain. I can't go for a walk. I can't do anything. It's affecting your sleep. Then that's the time you need to consider. You have tried everything. Nothing has worked. Then you need to consider. If something is working, even if it's ice pack, TENS machine, cream, anything you tried and that little bit of managing it, go on it. Keep it up as long as you can. As long as you can keep it away from the drugs, it's okay. Another question I get asked, I'm going on holiday. I'm not in too much pain. Can I have one? I would ask them all about this, where you're going on holiday, what you're intending to do. If it's just a time away from home and just with a husband and things, I'd say, put up with it. Because invading to the joint is far more risky to their holiday if they're not making too much of memories with their grandchildren, parents, and children, and all those things. Loads of people, they go on family holidays. They take their grandchildren, daughter, son, all those things. They don't want to be in pain when everybody's having fun. That affects their confidence, affects their memory. They'll all do it straight. Okay? Do you have any questions? So read the article which I put it in there. It'll give you a load more information.
What's the waiting for an appointment?
Here, we'll get it done within a week. Tomorrow, I'm not there. I'm not available. I think tomorrow, next week, definitely. Within a week, we can get it done. It's not that long. And we do have this request, I'm going on a holiday tomorrow. Can I have one today? We'll get them in somehow. We'll get them done. So again, you need to think about, even if people are listening on the call here, you need to consider, have you tried everything else? Have you tried all the medications available on the market before you go on this mother of all the drugs? Okay. Then finally, do I need it or do I want it? If you want it, then you wait around and manage with other stuff, go around the blocks few more months, then come back. If you need sleeping terrible, then do it. Okay? And I do all the joints, except the spine, I do everything. Weird enough, smaller joints in the hand, carpal tunnel, these are all my special interest. Carpal tunnel is the nightmare one for many people to do. I hold my breath and do it just easy as that. Honestly, I don't know how, it freaks me out sometimes, but it's quite my good interest in anything in the hand and the feet. I do it quite a lot. People come with the plantar fasciitis. This is another big question we hear. Plantar fasciitis. First half an hour, murder. And I can't walk. I'm in loads of pain. And I would check and make sure everything is okay, then I inject them. Again, steroid works far better. Thank you, Xavier, for helping Lewis. That's good. Amazing presentation. That's good. Nabil. Oh, that's a physio. Okay. That's good. So, yeah. Interesting conversation I have with people, but people will come up with the different questions all the time. But again, anytime, if you have any questions, speak to one of my colleagues as well. They do talk quite a lot about it because we have done loads of these training for them as well. So they understand it pretty well. But again, always this injection business is complicating, controversy, but it works amazingly well. Okay. Any other questions? Anybody else on the live stream? Is Natalia there as well, or she's not in? Okay.
Sure.
Okay. She was checking on making sure everything goes well. One of my colleagues. Perfect. Okay.
Thank you.
Thank you very much for joining us today. Hope it was useful.